So when we talk about blood cells, what are the cells that we are talking about? Essentially, we are talking about the three components. So when you talk about that, you've got the red cells here, you've got the white blood cells, which are shown here. Then you've got these anucleate cells, which are the platelets. So effectively, you have two kinds of anucleate cells, which is the red cells as well as the platelets. The platelets are here. They are granular versus the red cells, which are usually agranular, and they are pinkish in color. And the stains we use for peripheral smear are the Romanowsky stains. So they give you a range of hues to see your cells with. And when we talk about the white blood cells, which are the most common types, so this is a neutrophil, this is a eosinophil, this is a monocyte, and this here is a lymphocyte, and this here is a basophil. And what about this? This is also a lymphocyte. This is a large granular lymphocyte. So these are the 5 dominant cells that we see in the peripheral blood. So most often what happens is that when we have reactive lymphocytes, they become difficult to distinguish from monocytes. So let me show you how we can do that. So when we talk about lymphocytes, usually their cytoplasm is more basophilic than a monocyte, which is usually a grayish blue cytoplasm. Also, the nucleus of a monocyte tends to be more irregular. And this you will see further down the lane in my talk. With respect to neutrophil, eosinophil, and a basophil, you see that all these three are granular cells, but the kind of granules they have, they are very different from each other. So neutrophils, it has got primary as well as secondary granules, but they are usually relatively, they don't have a thick core, they are fine granules. While in an eosinophil, you see that the granules, they are much thicker, and I'll show you cases of eosinophilia in my talk in the upcoming slides. For basophils, we have darker granules, which are called basophilic because they bind to the basophilic component of the dye. So this is these granules, they are purplish in color, and they are again thicker granules. So these are the common blood cells that we see. So we'll cover all of them one by one. So first we'll talk about the red cells. So when we talk about the red cells, they are effectively cells that are biconcave. So biconcave means that the sides are fat and the center is thin. So how do we see it? So if on a glass slide where we see red cells, we can't see the biconcave shape of the red cell. So what we see are essentially round cells if they are normal. And all these round cells, they will be having a peripheral, nice hemoglobinized part, because this part of the biconcave part, that is thicker, and the center will be pale. So effectively, how you see red cells are round cells with a central pallor and the peripheral rim of hemoglobin, which stains reddish to pinkish with the Romanowsky stain. For red cells, their normal volume is about 92 plus minus 9 femtoliter, which means 83 to about 101 femtoliters. Practically anything over 100 we call as macrocytic, anything less than 80 we call as microcytic. So we divide based on the MCV anemias into normocytic, macrocytic, and microcytic. And with the modern cell counters, this is very easy to see when you have the CBC report with you. However, if you don't have that, then on the slide, the helpful cell on morphology is the nucleus of a small mature lymphocyte. So a normal red cell should be the same size roughly as the small mature lymphocyte nucleus. However, macrocytes will be larger and microcytes will be smaller than that. Now, before we embark on this journey, what we need is that we need to know the reference ranges for normal. And normal means that it is not just adult female and adult male normals, it is also the reference range for the children that is important. So this is our ever helpful DC at its best. So we have the reference ranges for all the CBC parameters with respect to the date and the day. So this is important to remember because when we talk about a neonate, something that is macrocytic for an adult is absolutely normal for a neonate. If you look at the MCV, the normal MCV will be about 110, which you will classify as macrocytic when you talk about an adult male or an adult female. So what do we mean when we talk about normocytic normochromic red cells? On the left is a low power image. And if you see, you've got two WBCs in this. So you've got a lymphocyte and you've got a neutrophil. Lymphocyte you use as a guide to talk about the red cell size. So most of the red cells, as you can see on this higher power image, most of the red cells, they are the same size as the nucleus of this small mature lymphocyte. So this is a normocytic normochromic blood picture. This can be either normal or this can be also seen in various types of normocytic, normochromic anemias. So when we say normocytic, this is the cell size. When we talk about the normochromia, it is that the central half to 1/3 should be the pallor, and that is what we see here. So if the pallor increases, then it is called as hypochromia. So we'll start with the first poll question. All of the following, they are causes of normocytic normochromic anemia except, and you have these 4 options: PNH, anemia of renal disease, sickle cell anemia, and pyridoxine deficiency. So do we have the answers?
We are getting answers like 4 and 3.
Okay.
4 and 3, most of them are answering.
So everybody who's answered 4 is correct. So pyridoxine deficiency usually causes a macrocytic anemia. Sickle cell anemia is not, is classically a normocytic normochromic anemia unless and until you're dealing with sickle beta thalassemia. And anemia of renal disease usually again is normocytic normochromic. It sometimes may have a microcytic component, but by far it is also classified into the normocytic normochromic anemia. So the correct answer is pyridoxine deficiency. Now, the other terms when we think of, when we talk about blood cells and when we read the books, that is anisochromia and anisopoikilocytosis. So when we talk about anisochromia, that is a difference in the hemoglobin content of different RBCs, and anisopoikilocytosis is when you have a difference in the shape of the RBCs. So in this picture, you can see that you have both anisocytosis, you have anisochromia and you have anisopoikilocytosis. So let us look at the high power images to look at all these things clearly. So when you look at the image on the left, you can see that you've got cells which are relatively less pale, so which have more pallor. For example, the small microhypos here, another ellipto here, these are paler cells when you compare it to these two. So these two, they look fairly normocytic normochromic in size. So when you look at the next image again, you can see the anisochromia very well. Even in the lower images, you can see that you've got normal hemoglobinized RBCs and you've got hypochromic RBCs. So this is called as anisochromia. Now, when we talk about anisocytosis, it is cells which are of different sizes. So again, on the left, if you see here, we've got small microcytic hypochromic cells. Again, here we've got hypochromia and we've got microcytosis. Along with that, we've got erythrocytes. So the part that you have microcytes and normocytes, that is anisocytosis, and the part where you have erythrocytes and where you have some target cells and teardrop cells, that is called as poikilocytosis. So in this image, what you see is effectively a small mature lymphocyte nucleus. In addition to that, there is the RBC picture, which is dominantly the microhypo picture. You've got NCNC cells, which are here. So this particular cell is a normal cell, this particular cell is a normochromic cell, but there are other cells that are hypochromic. In addition to that, there are these erythrocytes. So unlike the red cells which we see, erythrocytes, they are like an ellipse. So the borders, so the cell becomes more elongated. And how do we distinguish it from the pencil cell? So pencil cell is as thin as a pencil. So therefore it is called as a pencil cell. So this is the morphology here. And you also have the teardrop cell here, which is highlighted. So these teardrop poikilocytes you frequently see in nutritional anemias also, but also when there is marrow infiltration. So they are called as teardrop because they've got one pointy end and they have the other cell that is a complete round. So practically like a drop. So this is the classical image of a microcytic hypochromic anemia, and this is what you see on the hemogram of this case. So if you look at the hemogram, this is the Siemens ADVIA equipment. So the hemoglobin is low, that is 6.3. You've got MCV, that is 58.9. Always look at the RBC count. So for a hemoglobin of 6, you would expect the RBC count to be about 3 million. And this is the RBC VHC histogram, the volume gram and the volume histogram, and you will be shown this multiple different counters in the subsequent lectures. However, what I need to show you here is that in the ADVIA, you get based on the volume and the hemoglobin concentration, it is divided into these 9 quadrants. So your patient lies here, which means that the cells are microcytic and hypochromic. But what else did the hemogram show? It showed relative erythrocytosis as well. So as I said, for a hemoglobin of 6, you would expect the RBC count to be somewhere around 3 million, while it is at 4 million. So very likely this patient also has a concomitant high trait. Now distinguish the iron deficiency smear from a thalassaemic hemoglobinopathy. The cells that you see here in the peripheral blood, what do you think these cells are? And I'll give you a second to answer. So I'll mark the cells. So this particular cell. So let's see what you think of. Yeah. So I have started seeing responses that these are nucleated RBCs. And nucleated RBCs, why? And you have a lymphocyte in the same field. When you look at a lymphocyte, it has got a pale bluish colored cytoplasm. The chromatin, although it is condensed, you can still identify the nuclear details very well. While the nucleated RBCs that you have in this smear, most of them are late erythroblasts. And what you see is that the cytoplasm resembles that of a polychromatome. So here in this image, you see these cells, they've got relatively denser, very, very pycnotic looking nuclei. You cannot make out the cellular details very well when it comes to the nucleated RBCs vis-a-vis the lymphocytes here. So sometimes these nucleated RBCs, they create a confusion. You may think that you're seeing more lymphocytes, or sometimes when you have the intermediate NRBCs appearing in the peripheral blood, you have to again distinguish them from something which you usually don't see in a peripheral smear, and that is a plasma cell. So the NRBCs, they create sometimes diagnostic confusions. The other cells that this image is showing is also another one. Let me mark it for you, and then you can tell me what is it that we are looking at. So what do you think this is? So I see a lot of people are joining the meeting, but I don't see answers for this question. Let me point it out here. So any guesses on what these cells are? What this one is in particular?
No answers yet.
No answers. So target cells.
You target
There are a few answers.
Target cells, there are answers.
So the answer is target cells, and these are called target cells because they've got the shape changes. So you have not just pallor at the periphery, but also in the center. So it practically looks like a target when you're seeing a dart game, or when you're using the. So that is why it is called as the target cell. Okay, so let me ask you one more, and let us see why. So can you see this gray cell here? What is this? You also see this over here. So these are again some interesting cells which are not exactly, which are anucleate, but these cells, they don't have the pinkish or the orangish color of the cytoplasm like that of RBCs. Instead, they have a grayish color of the cytoplasm. So these are polychromatophils. So when you have polychromatophils, they will look like this. I can understand why somebody called it a blister, but this is a hypochromic polychromatophil. So in a thalassemic patient, it looks like this. We'll show you, I'll show you other examples. Of polychromatophils in the subsequent slide. So the hemogram of this case, this is one of our Sysmex counters. So you can see that there is a huge nucleated RBC population here, which the counter wasn't able to discriminate from the lymphocytes. So the WBC differential here is erroneous, and you can make this out based on the flags that the equipment generates. And when you look at the RBC histogram, these microcytes, they are interfering with the platelet and RBC discrimination. So you've got all these large platelets that are actually not large platelets, but these are microcytic hypochromic cells which are counted here. So I'll ask you a question now. You have to identify the pathology based on the hemogram and the image provided. Are you dealing with a BTT, an iron deficiency anemia, a BTT with IDA, or a beta thalassemia major? So what are we looking at?
We are getting answer 1 and 2. 2 ID. Yeah.
Okay, so the difference from a regular IDA, this image, this hemogram effectively tells you that you are looking at a hemoglobin of 11.8. You're looking at relative erythrocytosis again, and you have microcytic hypochromic indices. If you look at the RDWCB, that is only 18. Plus, what you see on the smear is that everything looks fairly uniform. So all the microcytes, they look like they're the same size. So this is actually an image of a patient of beta thalassemia trait and not that of IDA. So whoever answered, one was correct. So now in the next image, I'm trying to show you macrocytic red cells. And how do we understand they are macrocytic? Again, by comparing them to the size of a small mature lymphocyte. But in addition to macrocytes, if you say have a look at the smear here on the left. So this is a small mature lymphocyte. You've got certain other cells as well here. So you've got this, which is like a oval cell, but it is larger. In addition to that, again, there is a polychromatophil here. There are a few teardrops. So this is a patient of a macrocytic anemia. And there are cells, again, look at this here. So these are effectively your macroovalocytes. That these are cells that are larger in size, but they are oval in shape and they are not round. So this is the macrocytic macroovalocytes, which are again a sine qua non of B12 deficiency or folate deficiency anemia. So these These are the particular cells, macrovalocytes, that when you see, you can distinguish your regular macrocytic anemia of, say, liver disease or hypothyroidism from that of B12 folate deficiency. Now, the other cell that helps you, another feature of macrocytic anemia due to B12 and folate deficiency is this basophilic stippling. So when you see this RBC, this has got fine dots in the background. So this is what you mean by basophilic stippling. And can somebody identify the cell that has just popped up in the inset? So this is
Waiting. Hypersegmented.
Yes, we're getting answers.
So all of you are absolutely right. This is a hypersegmented neutrophil. So when do we call a neutrophil as hypersegmented? We call a neutrophil as hypersegmented when you have even one neutrophil with 6 lobes or more, or when you have at least 3 to 5% of neutrophils with 5 lobes and more. So when we look at this hypersegmented neutrophils, now the idea is that the lobation should be distinctly defined. So the thread that is connecting here, this particular thread, it should be less than 1/3 of the maximum width to be called as a definite lobe or a distinct lobe. So this is something that we need to be careful about. So hypersegmented neutrophil, again, you see in B12 folate deficiency anemias. In addition to that, they are also described in patients with uremia and in iron deficiency anemia. Again, now this particular cell you identified correctly in the previous case. This is again a nucleated RBC, but here the nuclear details, they are relatively more discerned. And this is, so I've got so this is a NRBC, Dr. Sanjeev, you're absolutely right. But this particular cell, this is relative, an orthochromatic one, and yet the nucleus is sort of lagging behind. So we possibly have a megaloblast in the peripheral blood. So I had a request to repeat something, and I think that was the distinct lobe definition of a neutrophil. That is 1/3 of the maximum size of maximum width of a lobe. That should be the thread. That should be the size of the thread. So if it is a very, very thick thread, or if the discrimination between lobes is not distinct, then you cannot count them as two lobes. So this is the hemogram. This was generated on a XC series of cell counter. So what you see is effectively macrocytic anemia, and very frequently in megaloblastic anemia, you will also have reduction in the platelet count and sometimes even the TLC. So this is a classical cause of cytopenias with a cellular marrow, and this is what you see on this CBC report. And this is the shoulder that contains the macrocytic red cells. The entire peak has shifted right, but these are the large macrocytes which are present here. Now, the other features that you may see in a megaloblastic anemia are things like this. So can anybody identify this? The cell shows some basophilic stippling in the background. In addition to that, yes, all of you are right. So this is the Cabot ring. So these are the Cabo rings. So Cabo rings you see as these figure of 8 or a thread-like material lying inside the red cell. So this is a Cabo ring. And a bone marrow is avoidable in nearly all the cases of megaloblastic anemia. But if you do that, what you see is you have a normal marrow on the right side. On the right side, you can see that this is a polychromatic NRBC. So these are their orthochromatic NRBC, and I've taken this from the ASH image bank. While if you compare your cases here, your cells here, these cells, they are larger, and it feels as if the nucleus is lagging behind and the cytoplasm continues to progress. So effectively an orthochromatic cytoplasm with a polychromatic nucleus, and so on and so forth. That kind of a picture you see here. In addition to that, there is an important change to observe. That is the presence of these giant stap forms, giant neutrophils, and a few giant metamyelocytes as well. So the myeloid series, that also shows these changes. So let me ask you another poll question. So there is a finding that is highlighted by the arrowhead. How would you best describe it? Is it a fine basophilic stippling? Is it a coarse basophilic stippling? Pappenheimer body or Howell-Jolly body? So I've got an answer of 2, that is coarse basophilic stippling, and you are absolutely right. So when you see coarse basophilic stippling on the peripheral smear, and you're distinguishing it from fine, because fine basophilic stippling, they are very thin dots in the cytoplasm of the red cell, while in the coarse basophilic stippling, you've got very thick sized dots in the RBC. So this you see in lead poisoning classically, and it is described with that. In addition to that, in this smear only, you've got another RBC here which contains some amount of stippling. Here it is very difficult to call it coarse or fine. So this would still go as fine, but this particular RBC is distinct coarse basophilic stippling. And I asked you about Pappenheimer body. So sometimes in the RBC, you see these inclusions as well. So this is a post-splenectomy smear. And can you see these inclusions? Now, these inclusions, they are called as Pappenheimer bodies. So compare it with the color of the basophilic stippling and the location. So Pappenheimer bodies mostly are near the membrane. And these are, again, darker, thicker in consistency than the basophilic stippling. In addition to that, you can distinguish it from Howell-Jolly body, because Howell-Jolly bodies are very round. And they are distinct. You may see 1 or 2 per cell, but they are very distinct rounds left over DNA material, while Pappenheimer bodies, they are the iron-containing siderotic granules that are remaining here. Now, another term that we frequently see is called as the dimorphic red cell picture. So dimorphic anemia typically is said when you have a dual deficiency, that is a B12 folate deficiency. Along with that, you have an iron deficiency. So you have hypochromic macrocytes, while more frequent than that is actually this dimorphic red cell picture, which occurs when you have a patient who's been given a transfusion. So if you have a look at this particular patient's parent population very likely is this microcytic hypochromic population. And because of the transfusion, there are these larger cells and completely normal in hemoglobinization. So these all are your monocytic normochromic cells. So can somebody tell me what is this particular cell that they are looking at, this white blood cell? Very good, Pallavi. So you were the first one to answer as eosinophil, and this is a neutrophil. So you can make out clearly the difference in the granules. So when you look at the eosinophil granules, they are thicker, they are more orangish in color. And in a neutrophil, the granules, they are very fine and they are usually purplish or pinkish magenta in color. There are both the kinds of granules in a neutrophil. Typically, eosinophils are described as these spectacle-shaped cells, but very frequently when you get eosinophilia, you don't just get a eosinophil with 2 lobes. More often than not, you'll have eosinophils with 3 or even more than 3 lobes in the case of reactive eosinophilia. So don't get hassled by that. That is not something which makes a eosinophil. eosinophil abnormal. Similarly, for the granules also, the eosinophils may lose their granules when they become abnormal. So again, you have to be very particular about not just limiting yourself to the density of the granules to call a cell as an eosinophil. I'll show you examples of all those in the subsequent slides. In addition to that, when you talk about the distinction between an eosinophil and a neutrophil, typically when the eosinophils, they lose granules, they still have a very pale cytoplasm. It doesn't have other granules. So that is again a helpful feature. So these are two examples of drug-induced macrocytosis. So we were talking about macrocytic anemia before I switched gears into Q2 eosinophil. So this on the left is a CML patient on nilotinib therapy. In fact, for TKI therapies, very frequently they cause macrocytosis. And this is a patient of acute promyelocytic leukemia on maintenance. You just see macrocytic cells. It's not really very anemic, but you have these macrocytes. So on the left, um, you have a lymphocyte here in the field in this, sorry, in on the other one. So this is a lymphocyte here. And you have, so this is the lympho, and you have macrocytes which look fairly uniform in size. So this on the right is an MCV of 114, and you can see that you again have mostly macrocytes and not really macrovalocytes. There is a wide list of drugs which can cause macrocytosis, either due to cobalamin deficiency or by causing a folate deficiency. Now, besides the usual non-mo, macro, and micro, you also have typical features. For example, you've got polychromasia and spherocytes. So these are two cases, and you can distinctly see spherocytes. Can you identify spherocytes here? So let me mark them for you. So these are spherocytes. So these particular spherocytes, they are cells which now don't have a central palate because they are no longer biconcave, but they've become spheroidal. And in the case one here, you again have predominantly spherocytes and you have polychromatophils. So case one shows you essentially only spherocytes and polychromatophils, while case two, it shows you the presence of NCNC cells, spherocytes, as well as polychromatophils. So this is the hyper image of the case one, and this patient had AIHA, it was DCT positive, and this was the hemogram. Thanks to the polychromasia, there was an elevated MCV. Case 2 had a positive incubated osmotic fragility test, and this patient was a case of hereditary spherocytosis because this was DCT negative and the incubated OFT was prolonged. Now, in addition to that, you have cells that can be called as pincer cells or mushroom-shaped cells. So if I mark them here, so I'll take a laser pointer to show you. This particular cell is a pincer cell or a mushroom-shaped cell. So if you see this in addition to a few spheros, you're likely looking at a band 3 deficiency. And you can further do the EMA dye binding test, which shows a reduced fluorescence in patients of HS. Or instead of doing the conventional incubated OFT, you can also do the flow cytometry. OFT, you have access to a flow cytometer. Now, these are two more findings that you find sometimes. So, in the left, you have a roulet formation. So, roulet formation is called as stacking of the RBC. So, stacking of the RBC means that RBCs, they are like this. So, you have 2, you have 3, you have 4. While on the right, you've got agglutinates. So, these agglutinates, they are less. So, this is like a clump of RBCs. It is no longer as a RBC clinging together in a line formation. So Rouleau formation you see whenever you have hypergammaglobulinemia, and sometimes in very severely anemic patients also you may find some Rouleau formation. Agglutinates, on the other hand, you see when there are cold antibodies. So these cold antibodies may be primarily due to cold agglutinin disease, or it may be a secondary cold agglutinin. It may be a primary cold agglutinin syndrome, or it may be a secondary cold agglutinin disease. So Rouleau formation on the higher part, you can make out that this smear is showing a nice RBC stacking. So RBCs, they are clinging to each other, but they are not really forming clumps. So this is what happens when you have a hemogram of a patient who has cold antibodies. So on the right, you can see these clumps, and there is a loss of the rule of 3 when it comes to the hemoglobin and the hematocrit. The RBC count artificially is lowered, the MCV is elevated, and you have a very, very dramatic increase in MCH and MCHC. So if you have this kind of a CBC report with you, what should you ideally do? What should be your next step? Will you release the results of CBC after verification, order a B12 folate assay, warm the sample, rerun, or do a DAT? So
most of the people are answering 3.
Yes, so all of them are right. So this particular sample, you will always warm and rerun, and you should also make the smears again. So on the left, you can see that the agglutination has resolved. Post-warming. So this is again when the sample was rerun after warming, you can see that the MCH, MCHC, they are correcting, RBC count has become a little more elevated, and the rule of 3 for hemoglobin and hematocrit is maintained. So now the other finding that we are used to seeing, or that we have to watch out for, is the presence of sickle cells. The sickle cells, when we look at sickle, we remember that classical Hasiya, the sickle. However, so somebody asked, what is the rule of 3? That is hemoglobin into 3 should be the hematocrit. That is the rule of 3. So sickle cell anemia here, you can see that you've got a range of RBC abnormalities, the most distinct of which is the presence of these long elongated cells, which are hyperdense and they are hyperchromic. So these are elongated, very pointy cells. They're not like the pencil cells, which were hypochromic, which had parallel sides and which you also can see here. So this is like a pencil-like cell, while these hyperdense cells, these are sickle cells. In addition to that, in a case of sickle cell anemia, you will frequently find target cells and other abnormalities. This is a high power image. So I'll ask you another question now. Let me see whether you can identify this or not. So this particular RBC contains something. This RBC also contains something. Can you identify what is this? So Howell Jolly body, very good. So sometimes we have platelets that fall on an RBC and they look very similar to a Howell Jolly body. The key to distinguishing it is to compare the color of this inclusion. So the color of this inclusion matches that of the nucleus of a lymphocyte, and this is because it's a nuclear fragment in the RBC. And as I said, the NRBCs, they've got very pycnotic nuclei, so that is the kind of pycnotic nucleus or pycnotic nuclear material that is left around in the Howell Jolly body. So you can quickly do a confirmation by doing a sickling test. For bite and blister cells, so these are cells that are called as bite cells because you see that there is no, the continuous rim is not there and it is like you've got a shape like this. So this is a bite cell, and this particular cell here is the blister cell. So all the hemoglobin, it has moved on one side, and you've got a thin membrane that is left on the other side. And this you classically see the G6PD deficiency. And on the right is the Heinz body test, which you can run in your lab. So now I have an interesting question here. So we usually have a tendency to describe cells like bite or sickle or teardrop. Can you tell me what bite cells are also known as? Okay, so podocytes are actually target cells. It is the keratocyte that is a bite cell. When we talk about dipranocytes, they are sickle cells, and dacryocytes, they are the teardrop cells. So this is a keratocyte. And we also have another cell which we should always inform as an emergency, and that is a schistocyte. So when you talk about schistocyte, on the left, there is a patient of HIV on therapy who developed GBP. So you see these hugely segmented neutrophils, almost like a macropolycyte here, in addition to the schistocytes that are present on this smear. So schistocytes are all these. And when you're dealing with schistocytes, the predominant background should be normocytic, normochromic, typically. You can identify all the cell fragments. So I would recommend that you go through the 2021 update of the ICSH recommendation. It is a free available article, and this tells you the kind of cells. So all the keratocytes, all the triangular schistocytes, and even the microspherocytes in this image need to be counted as schistocytes to give you a correct count. Now, this is a case of hereditary elliptocytosis, and you can see that most of the RBCs here are elliptical in shape. So this patient needs to be investigated for hereditary. Okay, so now this one, this particular image, I had clicked. This was one of our patients for who had been referred for thrombocytosis. So when you look at the higher part of the image, you can see a lot of echinocytes, but there are acanthocytes as well. So echinocytes are these nicely crenated RBCs, uniform crenations, thin crenations. However, acanthocytes are cells with uneven, long spicules. So these are the two different red cell, other red cell changes. So acanthocytes you frequently see when you have lipid abnormalities or when you have liver disease, and echinocytes you see when your samples being kept too long or when the patient has renal failure. In addition, in this smear you have thrombocytosis, you've got uneven platelet granulation, and you also have Howell-Jolly bodies. So now these cells, they are called stomatocytes. So when you look at these cells, it is like the central pallor hasn't remained central. It has become like a slit of pallor. So this is called as, these are called as stomatocytes. More often than not, they are sort of artifactual on the smear, and they may be present only on one part and not on the other part of the smear. But when you see it as a consistent anomaly, then you may initiate a workup for hereditary stomatocytosis. Now, can somebody identify what this picture is, what this peripheral picture will be called, peripheral blood picture, and why? So this particular peripheral blood picture is, so somebody said left shift, is left shift. But in addition to the left shift, you've got a nucleated RBC, which is which is sitting over. I think I have to keep switching pointers. So this is the nucleated. RBC here. In addition to that, you've got a cell which is sort of leaking something outside of it. So this is a leukoerythroblastic blood picture. I've got correct answers now. So these are basophils that you have. And these basophils, unlike the basophils that you see as the book picture, which is those hypergranular basophils that I showed you, these basophils, they've sort of lost the granulation. So how do you identify that these are basophils? These basophilic granules, they show this hue, this pinkish magenta hue around the cell. So this is, Dr. Anvesha said myelophysis. So there is myelophysis, but this basophil, this is a helpful cell and it gives you a clue to what kind of myelophysis the bone marrow will show. And that is a classical sign, the presence of leukoerythroblastic blood picture with basophilia that you're seeing here. It's a classical sign. Primary myelofibrosis. This is another high power image and you can see this basophil. Now this particular basophil you can distinguish from neutrophil as you don't have the fine granules. You have this purplish hue around the cell and there are vacuoles that are remaining in the cell from having the large granules which are now leaked out. In contrast, you can see the neutrophils here differentiate the color of the cytoplasm. This is a nucleated RBC and mark the basophil here. What you see on this side is a metamyelocyte, a larger than usual. And again, these teardrop cells, they come to your rescue. So unlike the teardrop cells that would occur in a case of iron deficiency anemia, these are fully hemoglobinized teardrop cells. So in a thal also you may find teardrop cells, thal major, but those are again hypochromic, while these, they are normochromic teardrop cells. And this particular cell also you may find when you're dealing with such leukoerythroblastic blood pictures with basophilia or in a classical case of CML. This nucleus is absolutely condensed. This is a megakaryocytic nuclear fragment, and this is not a normal white blood cell that you see in the peripheral blood. Now, in addition to all these, sometimes you may have the cryoglobulins in the peripheral blood, which you can see either as crystals in this empty space or as in this image, you have neutrophils which are containing these bluish inclusions. This one is extracellular and this one is intracellular. So this is a patient of cryoglobulin. Now we'll switch gears and move to WBC disorders. I've shown you this particular image of white blood cells. So when you look at peripheral smears also, or when you look at CBC reports also, you have to think in terms of absolute counts. So for example, I've given you a scenario here, 35% neutrophils, 4,000 TLC, 65% lymphocytes. So it looks like there is lymphocytosis. However, the patient actually has neutropenia. The lymphocyte count is well within. The normal limits. So these are the causes of neutrophilic leukocytosis, of neutropenia. of lymphocytosis, of lymphopenia, and you can all go through this. This is from our textbooks only. These are causes for eosinophilia and for monocytosis. So the key that you need to remember when you're describing white cells is to talk about their size in relationship to a small mature lymphocyte, to talk about cytoplasm to nucleus or nucleus to cytoplasm, describe it in that order. Then you have to talk about the cell shape and the membrane, whether it is round or whether it is irregular, what is the cytoplasm like, what is the amount, what is the NC ratio, what is the color of the cytoplasm, the amount of granules or no granules, the presence of vacuoles, the presence of or absence of or rods or inclusions. Following that, we talk about the nuclear shape and the membrane, that is round, oval, indented, smooth, regular or irregular, followed by the chromatin into fine, condensed, reticular or coarsely clump, and nucleoli, whether they are present or not, what is the number and whether they are punched out or invisible. This is another frequent change that we see in our patients. This is a reactive change. When you look at the granules of these neutrophils, they are more in number and they appear to be darkly stained than in the regular peripheral smears. So this is called as toxic granulations. In addition to that, you have got some vacuoles here in the nucleus and the cytoplasm. So this vacuolation also is a part of a reactive change. In addition to that, you may have dole-like dole bodies, which are these bluish colored peripheral inclusions that you may have in neutrophils. In the lymphocytes, you may have reactive lymphocytes, which were classically described by Downey into these three types. Type 1 was a relatively smaller sized nucleus. Instead of being round, now it shows indentations and the cytoplasm may have granules. Type 2 is another one that is common, abundant agranular cytoplasm. The cytoplasm, it appears to be slightly dark here at the periphery, and it has this tendency to hug the RBC. So this cytoplasm it's just sort of trying to go between these two RBCs. So that is a feature of the reactive lymphocyte. Now this third kind is the immunoblast-like, which has a very, very deeply basophilic cytoplasm. It may show you nucleoli because it's an immunoblast, and the chromatin is fine to coarsely clumped. So that is, these three are reactive lymphocytes. Another example of the type 2 is this particular one. So when you talk about this one, this again is showing you this feature of inserting itself or molding itself around the RBCs. So classically, these kind of Downey cells were described in infectious mononucleosis, but you will also see them in multiple viral infections when you look at the peripheral smears. So these are the three in the bottom are the plasmacytoid lymphocytes, while the two above, they are reactive Downey-like cells. So they are plasmacytoid. Why? Because the nucleus has become eccentric. Now they have a Golgi zone-like structure, and they resemble like plasma cells. So they look like plasma cells. So they resemble plasma cells, but they are not plasma cells. They are plasmacytoid lymphocytes. So these very frequently in the current season in Delhi, you will find in patients of dengue, in whose peripheral smears you get this around day 5 to day 10 of their disease when there is recovery that starts. So these kind of very heavily plasmacytoid lymphocytes you are able to see in these smears. Again, you've got a picture here which shows you a classical Downey type cell and a plasmacytoid lymphocyte. You can contrast the basophilia here. In the plasmacytoid lymphocyte, you've got a much more dramatic basophilia when you compare it to the reactive lymphocyte. Now, this particular image is that of a patient of eosinophilia, and you can see that most of the cells here, you've got a small mature lympho here, while all these are all eosinophils. So predominance of eosinophils and the number the general guide on the peripheral smear is that on a 40x smear, you count 10 fields and you take an average of those 10 and multiply it by 1,500 or 2,000 depending on the microscope. So this particular patient definitely has eosinophilia. So this is another higher power image. And if you look at this here, that this is what I was trying to tell you, that in a eosinophilia patient, you may not have all eosinophils with only two classical spectacle shaped nuclei. You may have more lobation. So these eosinophils, they are practically showing you three lobes around. In addition to that, you can make out the granules, and when you move the fine focus, you will see that there is a retractile nature to these granules. And these granules are sort of shine at you. That is another way to distinguish neutrophil from eosinophils from neutrophils. Now, in this particular image, this is what I was trying to tell you. So these two are here, the hypogranular eosinophils. So if you look at this, the granules, they are remaining only on one side. This is an uneven kind of granulation, and the cytoplasm at the back, if you look where there are no granules, that is almost like it's a faint gray blue cytoplasm. So they are hypogranular eosinophils, and these very frequently you find with the PDGFRA associated eosinophilia and the other myeloid lymphoid neoplasms which are associated with eosinophilia and tyrosine kinase fusions. So these kind of abnormalities are more common there. However, you may see them sometimes even in reactive eosinophilia. Now in this image, what you can see is a neutrophil here. These are eosinophils, which you can clearly differentiate from the neutrophil based on the color of the granule. And if you were to look in a microscope, even the refractile nature. And this particular cell here is actually a basophil, which is completely degranulated, leaving the vacuoles behind. So very frequently, dependent on the staining, the storage time, basophils, they have a tendency. To degranulate. So when they don't degranulate, this is what they look like. So you've got a patient of CML here, and you know that this is CML because you've got a complete series of left shift. You've got neutrophils, metamyelocytes, myelocytes, and even blasts in this, along with the presence of these very thickly granular basophils. So these are basophils with normal granularity, and I've shown you how hypogranular basophils can also look like. Now, in contrast to the case that I showed you, what is the dominant finding here, if all of you can point out? So there is definitely leukocytosis. In addition to that, what is the most dominant cell? How will you classify these cells? If anybody wants to take a shot. Okay. So you think they are reactive lymphocytes, okay? Monocytoid cells, okay? So how can we distinguish these from reactive lymphocytes? These are actually all monocytes, and they are not reactive lymphocytes because when you look at the nucleus is sort of very irregular in its shape. So it is not a round nucleus and not just a small indentation, but these nuclei, they're very, very variable in their indentation. So you have something which has multiple indentations like this. You have almost like an embryo-like nucleus here. So these are monocytes. And in addition to that, this smear is showing you these macropolycytes. So these two, they are macropolycytic neutrophils, almost like a not a diploid but a tetraploid kind of a neutrophil. So you've got macropolycytes and you've got monocytosis. This is a smear from one of our patients of chronic myelomonocytic leukemia. So primary abnormality was monocytosis. In addition to that, there is the evidence of macropolycytes and these hypogranular neutrophils, which is a feature of this. Dysplasia. Now, this is another cell which sometimes may confuse you with monocytes. When you identify what cell are we talking about, this particular cell, these are hairy cells. Very good. So, hairy cells, when you look at a CBC report on a Sysmex counter, will very frequently fall into the monocytic region, while on these smears, you usually have monocytopenia. So, you can't identify monocytes. How will you distinguish them from monocytes? When you look at the nuclei, again, see that they are essentially just about showing a very mild indentation or they are round. So reniform kind of a nucleus they are called. They are not very irregular. When you look at the chromatin, it is more coarsely condensed when you compare it to a monocyte. And you look at the cytoplasmic margins, they are fuzzy. And these fuzzy margins and these projections, they are, that is why the cell has earned its name of a hairy cell. Now, this is a case where you have lymphocytosis and you also have these basket cells. This is from a case of chronic lymphocytic leukemia. When you have a look at this, sometimes even postgraduates, what they do is that when they're given smears of CLL, they end up calling it as ALL. So the chromatin in a CLL cell, that will definitely be slightly less condensed than a conventional small mature lymphocyte. However, they do not show the presence of nucleoli in all the cells, and that is again a helpful feature when you have to distinguish it from acute leukemia. Now, these are a few more examples of lymphocytes which are showing cleaving. So these, although they are very small and they have a condensed chromatin, they have this sort of indentation, and this one here has a through and through cleave. So these are buttock cells and these are called cleave cells, and you can see them in patients of either follicular lymphoma or you can see them in patients of mantle cell lymphoma. And now these lymphocytes, if you have to describe them, they have these polar projections, and this is a patient of splenic villus lymphoma or splenic marginal zone lymphoma, and the lymphocytes very frequently end up showing these projections. Now, can anybody identify these particular cells here, the lymphocytes? Let me show you a higher power view. So what do you think these three lymphocytes are? So these three lymphocytes, they have granules in them. These are all large granular lymphocytes. So these, as you correctly identified, they are large granular lymphocytes. lymphocytes, and they can be present as a reactive change. They can be present in patients who have splenomegaly or who are post-splenectomy. But when you have them in huge numbers, you need to exclude large granular lymphocyte leukemia. And I talked to you about plasmacytoid lymphocytes. Let us try and identify the cells here. This was one of our patients who had flu and was admitted in the winter season. And we had all these cells in the peripheral blood along with Doulé formation. So these were plasma cells in the peripheral blood. This you can find in patients of plasma cell leukemia. So when we describe a plasma cell, it is a cell that has got an eccentric nucleus. It has got a basophilic cytoplasm. Many times in the peripheral smear, these plasma cells, they also show you these fuzzy kind of margins sometimes. So if you have a look at the margins here, they are a little fuzzy. And in this cell, this is almost like disintegrating. So you've got fuzzy margins. So this is a patient of plasma cell leukemia. Now, when we talk about blast morphology, and you will be taken through cases of acute leukemia. So when we talk about L1 blasts, they are mostly small with very condensed homogeneous kind of a chromatin, and nucleoli, they're either not visible or very inconspicuous. L2 blasts, on the other hand, they are slightly larger, heterogeneous. L3 blasts are the ones with vacuoles. So this terminology of L1, L2, L3 is no longer used, but I still thought I'll show it to you so that you at least understand what any of your faculty members mean when they talk about L1, L2 or L3. So this is the classical ALL, pediatric ALL kind of a picture where you have a small mature lymphocyte here. If you have to describe these cells, they are about the blastoid cells. They are about 1.5 to 2 times the size of this particular lymphocyte nucleus. And this particular cell, this has a very high NC ratio, very limited, small amount of blue cytoplasm. In addition to that, the cytoplasm has to be described as agranular cytoplasm, and there are no rods. The nucleus is round, it is condensed, and you have either indistinct or very punched out a single kind of a nucleolus. On the other hand, you have this 11-year-old male with abdominal distension. And when you have a look at the cytoplasm, it is deeply basophilic. It is showing these multiple vacuoles. And this is a patient of Burkitt lymphoma with spill in the peripheral blood. So this is the classical morphology of a Burkitt lymphoma. When we talk about the myeloid blasts, they can either be the conventional relatively agranular myeloblasts, and this odd rod is the sine qua non of a myeloid blast. In addition to that, you can have granular myeloblasts with 20 or more granules in the cytoplasm. Monoblasts, on the other hand, they are usually agranular, but when you look at the chromatin of myeloblast and monoblast, you see that in a monoblast, the chromatin is much more lacy and reticular. So if you have to describe this cell, this is a cell which is, if you have to compare it to a small mature lymphocyte, and if you don't have that, let us look at this NCNC cell as a cell reference type. This is almost like 3 to 4 times the size of a small mature lymphocyte. Then the nuclear, when we talk about the cytoplasm, this has a moderate amount of cytoplasm, which is agranular. It shows an odd rod. The nucleus is showing an indentation. The nuclear chromatin is fine, and you can see a nucleolus, which is prominent. So this is how you will go on to describe the blasts. Now I'm asking you another question. What is the feature that on morphology will tell you that you're looking at a AML? Is it an odd rod, granule, phi body, or a pseudoshadiac Hitachi granule? So everybody is answering one, that is odd rods. So odd rods tell you that you're looking at an acute myeloid leukemia. Now, these are other pictures from acute myeloid leukemia. In addition to the blast, you can also see the dysplastic neutrophils. Now, this is AML with monocytic differentiation. And as I said, the chromatin of the cell matters, and this is very lacy and it is very round. So you can appreciate the difference. This is an 821 AML, and this is a monoblastic acute leukemia, and you can clearly see the difference in the chromatin. So in megakaryoblast leukemia, your blasts, they may have blebs, and these are the blebs that can happen. This is almost like platelets budding out of the blasts. Now, let me ask you another question. All of the following, they are blast equivalents except your options are hypergranular promyelocyte abnormal, promyelocytes, promonocytes, and abnormal hypogranular promyelocytes. Everybody who's answered 2 is correct. It is a promyelocyte, a normal promyelocyte that is not a blast equivalent. So this is a hypergranular promyelocyte on the left, a hypogranular chromidocyte with this bilobed nucleus, but no granules or very few granules. And these are the promonocytes. So these are also considered as blast equivalents. And this is how you distinguish them. So this is a classical monocyte to a promonocyte with very fine chromatin, but indentations, a monoblast, which is nucleus with lacy chromatin, and an immature monocyte, which is somewhere between a mono and a promono. So now when you're counting the cells, promono and monoblast can be clubbed together and can be counted as a blast or a blast equivalent. However, the immature monocytes, they are the ones that need to be distinguished from promonocytes. So this is a typical field of a high count APL, and this is the image from the tail that I've taken. This is the area which is very enriched in these cells. Can you tell me what these cells are? The ones that are marked here, they are all abnormal chromidocytes, but these cells, they are marked and they are called as parvet cells. That is, bundles of or rods are sitting there. Now, another question is, if you see these cells on a PS on a Saturday, what should be your next step? Confirm by MPO staining. Wait for consultant to verify. Okay. Another confirm. Confirm by PCR. So everybody who's answered three, I'm glad that you answered three. You have to inform your treating physician to start therapy. Don't wait for MPO staining. Don't wait for your consultant to verify. If you've seen the smear even on a Saturday evening, inform your inform your treating physician that they should start the patient empirically on therapy. In addition to that, on the peripheral blood, you can also identify a lot of dysplastic findings in the neutrophils. So this is dysplasia in the neutrophils. You can see the pseudo-pelgariue anomaly in the neutrophil here. All these neutrophils, they are hypogranular. This is almost like a ring. This is a figure of 8. These are all abnormal segmentations in neutrophils that you can see. Keep in mind that the platelets should be stained well when you're talking about hypogranularity. Sometimes just because the staining is abnormal, it looks like hypogranular. Sometimes you can also find these OR rod-like structures in the neutrophils in the peripheral blood. Now, most of your modern cell counters also give you some indicators, that is a low neutrophil site scatter in site fluorescent light, or in the ADVIA series of cell counter. This is how the patient of MDS has a reduction in the peroxidase activity of, a higher peroxidase activity and a lower size in the neutrophils. So all of the following, they are features of dysgranulopoiesis except nuclear hypologation, hypogranularity, pseudo-pelgariue anomaly, or Shediac-Higashi granules. So the answers except the answer is 4. So these are Shediac-Higashi granules. So if you compare it to a regular neutrophil, these granules, they are much thicker than that. They are seen in lymphocytes, they are seen in neutrophils, and they are seen also in the monocytes. So these granules, they are very thick basophilic granules that you can identify. These are conventional Shediac-Higashi granules. Now, last words on platelet morphology. Platelets, as I said, are anucleate cells, 7 to 11 femtoliters in size. Large platelets are larger than 11 femtoliters, but they are still less than the size of a mature RBC. Giant platelet, you say when they are nearly the same size as that of a RBC. So here you can see the normal size platelets, and they have a tendency to form clumps when you're looking at a finger prick smear, or even in a case of a EDTA smear, you may get small clumps of 2 or 3 platelets each. So this is a peripheral smear that is showing extensive clumping, and very frequently these patients you will see as the counter would flag them as thrombocytopenia. So they are frequent causes of pseudothrombocytopenia. The other findings that you may see in the platelets are these platelet satellitism, that is neutrophil which surrounded by platelets, or you may have these giant or large platelets. So this particular platelet in the center is a giant platelet, nearly the same size of an RBC. This particular platelet would be classified as a large platelet. So in addition to that, when you're seeing large platelets, you should also look out for these dole-like inclusion in the neutrophil. Now this you see in a MYH9 related disorder. On the right, you've got very small platelets. This is Wiskott-Albrecht syndrome. On the left, you've got platelets that are not staining. And you know that the staining of the smear is fine because there is a normal staining platelet. But you have a variety of platelets here which are larger in size and which are absolutely blue. So this is a gray platelet syndrome. And this is a patient of Bernard-Soulier with these large platelets and thrombocytopenia. So I'll finish by telling you the take-home message, which is that use the small mature lymphocyte as a guide for the red cell size. The red cells you described as normocytic, microcytic, and macrocytic. White blood cells describe their cell size, cytoplasmic, and nuclear features. Also, look at the company the cells are keeping. So when I say look at the company the cells are keeping, it is the presence of basophils in a peripheral smear, which otherwise looks like a leukoerythroblastic blood picture. It is the presence of dysplastic neutrophils when you're looking at blasts in a smear. That gives you a sign that you're looking at an AML rather than an ALL. For platelets, you assess not just the number, but also the size, the granularity, look for aggregates. And if you have large size platelets and a history of thrombocytopenia, always look for the dole-like inclusions. With that, I would like to thank you and invite Roma ma'am to take you through her words of wisdom.
Ma'am,